Dr. Yasser Reda is currently working as a senior consultant anesthesia and chronic pain management in Hamad Medical Corporation, Qatar. He's the head of intervention pain medicine in post anesthesia care unit and HMC, head of the block room for regional anesthesia and intervention pain, course director of ultrasound guided regional anesthesia and pain intervention. He studied anesthesia and chronic pain management at Cancer Institute, Cairo University, Egypt, award 2001. He's an Arab board of anesthesia and ICU, Cairo, Egypt. He has European diploma in anesthesia, Sweden. He has European diploma of regional anesthesia and acute pain. He has an European diploma of pain medicine, Dublin, and he has a certification of intervention pain sonography in USA. He has following intervention pain practice in USA. He has an ASRA and pain and ultrasound certification. He has ozone therapy and diploma, and he has American Board of Anesthesia, American Board of Headache, and he has published many papers and editors of pain books, and he is the speaker and faculty in many local and international conferences, workshops in regional anesthesia and chronic pain and difficult airway workshops. Dr. Yasser has a very good bio and he is a good lecturer as well. The lecture for Dr. Yasser is very interesting. Usually now about additives of local to local anesthesia. Many people are using more additives nowadays, and Dr. Yasser will give us a very please, Dr. Yasser.
I'm just very proud to be in one of this group, and thank you, Dr. Saad, thank you, Dr. Tahir, and all the attendees for joining me today. I can see good morning, afternoon, or good evening, whatever you are in part of this continent. I don't have any conflict of interest for my topics here, but I will speak an objective about few things about additive for local anesthesia. So I just will give you a brief introduction about local anesthesia, how it works, and how why put an additive for this local anesthesia. And I just give you a brief word also about the adjective for regional anesthesia. I will just give you a few words about definition, risk, benefit, indications, different classes, safety issue, future of the additives, conclusion, question and answer. First of all, we can agree with each other that regional anesthesia now become a very big part of anesthesia, and it become a second option or sometimes first option. And the concept of opioid-free anesthesia or opioid at least less anesthesia become very common and used all over this continent. And also because of ultrasound safety and putting a catheter for anesthesia and analgesia increasing in number, but still most of the people use a single shot and they want to get more time with this regional anesthesia, so additive may have a role in that. Also, we must know most of the regional anesthesia available in the market up till now have a limited time and you can't use for many days, but still in the future some promising stuff on horizon to come to the surface to give you a long acting local anesthesia. So wherever you have a surgery or trauma in your life, you need analgesia and anesthesia. Whatever you use a regional anesthesia or even general anesthesia, I don't guide you to do one of the two, but do what you must all the time, because what's called safety is a paramount. What we need from the patient to get a very smooth recovery and a very safe discharge to recovery or to his house without complication. So I just give you just a brief introduction about nerve conduction and how the wave transmitted to the brain, or just how the pain transmitted to the brain. First of all, we have many fibers, and every fibers have a function in transmitting something or just giving a clue to the body about the position or to give some sensation for the body. But the most important for us here is the pain fibers. We have two pain fibers, what we know now, two pain fibers, one for fast pain, which transmitted the pain very fast and give you a protective mechanism, which is called E delta fibers. This is small fibers, myelinated, very fast conducting. And you have also the delayed pain transmitter with C fiber, which is not myelinated. And this will give you secondary pain or second pain with dull pain and sometimes given from the viscera and the second pain or coming after this first pain. Again, the nerve is a bundle, and this bundle contains all the type of fibers, all the type of fiber found in the nerve bundle. But what we are concerning in anesthesia and analgesia was called this pain fibers. And secondly, in some cases like orthopedic, when I need more relaxation and I don't need any movement, I need also the motor fibers. So this is a bundle included in the fascial plane. And there is many fat in between. There is a vessels in this bundle because this is a very important and concerning. And you must remember also why the transmission coming fast by this myelinated fibers. They said that it's jumping between node from here, but I don't know how it's jumping. But it said that because it gives a fast jumping pain to the signal to the brain. And remember that the pain pathway is two ways, not just one way. He given a projection to the brain, and the brain give an order and projection for the body, for immune system, for regeneration, and for response to the brain. And the brain also gives some experience about pain, especially in chronic pain. And how this pain happen? Usually it starts by, as I told you, surgery or just an trauma. Inflammatory mediators come from the tissue destruction, and this inflammatory mediator activate first A delta fibers and later C fibers, and this give an action potential to the nerve. And nerve is not a continuous cable; it is just a cable and gate to the brain. And this give an type. Gives the brain the clue about the types, the severity, and the reaction to this pain transmission. And this happened like every part, what's called in every part in the body, which is giving you a life thing, give an action potential like a heart, like a nerve, like everything in the body. So, but remember that we don't speak only when I speak about local anesthesia, I don't speak about sodium channel only, because some action for local anesthesia not explained by sodium channel. And you must remember there is many channels and pathway join in the transmission of the pain. So whenever you block one of these receptors transmit the pain, it can give you more analgesia and more anesthesia. And this is the idea behind using the additives. So the mechanism of action of local anesthesia, what we know all that blocking the sodium channel blockers, it may block from inside, which is a very common theory, or from conformation change from outside. But this is a very common mechanism we know. But unfortunately, many of the pharmacological action and many of the side effects can't be explained by sodium channels. So we have also calcium and potassium channel effect, and transient receptor potential valenoid receptor effect be blocking, and also reduce the inflammatory mediator like dexamethasone, and reduce free radicals and decreasing the edema, so decreasing the pain. And there is also some mechanism not related to sodium channels. This observation observed from using local anesthesia, like antithrombotic independent for sodium channels. Lignocaine also have a modulatory effect on N-methyl D-aspartate receptors. In some chronic pain, infusion of local anesthesia can give you many months pain relief, and this can't be explained by sodium channel. Also, lignocaine in a regular dose, normal dose, is an antiarrhythmic, and neuroprotective. But in higher dose, it can be arrhythmogenic and neurotoxic. Also, they found that bupivacaine also have an efficient activity against microorganisms, like an antiseptics. So before to go for additives, how it work and how can we do it, I'm just giving you just some time. If you delay even the physical parts for the local anesthesia, it can give you something don't expect, like when just you warming local anesthesia to body temperature, because usually you preserve it in a very low temperature. It can give you a very short time just for local anesthesia to act about 10 minutes instead of 20 minutes for BBVK. And this is not affecting at all the duration for the local anesthesia. And there is many paper published for that. I remember one of my colleagues, Dr. Macharita, sent me his paper about that. And I found this paper in Brazilian Journal of Anesthesia. So playing in the physical parts or chemical parts can give you another action for local anesthesia. So I'm just speaking, what is the factor affecting your choice? Usually when I make a block, I'm thinking about choice, lidocaine, bupivacaine, which drug is suitable and which dose is suitable and which volume is suitable for local anesthesia. And this is guided usually by length of the operation. If I need a long operation, I need a long local anesthesia. Type of operation, usually operation in myotome, different from dermatome, from osteotome. Sometimes in operation, I need more relaxation. I need higher dose with higher concentration. Post-operative pain, it's very important. If I need this operation known that have post-operative pain, I need a long time for long-acting local anesthesia, and sometimes I give an additive with that. Daycare or inpatient for the medico-legal problems if you live in numb limb and to go home without and protection. Body weight of the patient, for example, 128 kilogram and very tall, very big person, different from a small person, 40 kilogram. Associated disease, like if the patient have a diabetes, hypertension, or any demyelinating disease. For example, if you have a low sensation for diabetes, you give usually a low dose and low concentration. It can work very good because you already have an hypoesthesia. But in some diabetic patient, if you have hyperesthesia, you need a normal dose for these people. Age of the patient, very important. You know, neonates different from 107 years and different from adults. 6. Because usually most of the time you can get a local anesthesia, systemic toxicity is more higher incidence in the female. Other factor, you have what's called a problem for using the local anesthesia, like allergy or any other problem with using special local anesthesia. So additive, just in simple word, you remove one and to put two. Why I put two? To get better quality for analgesia, to get a short time to work, long time to act, and a good quality for local anesthesia. Away from all the additive, we know the highest evidence gated from the adrenaline. But weak evidence come from other drugs. But also important thing to remember, because adrenaline or epinephrine have more than now 100 years to be used. So have some evidence, but this not means that the other local anesthesia or the additive, if not use it for a long time, because there is deficient study, don't have good evidence. So according to our study, marriage is the main reason behind divorce, but must remember that the absence of evidence, because there is no evidence, is not evidence of absence. So what about the ideal additive? The ideal additive to have a very short acting to work, and time is life, to have a prolonged action, to reduce its doses and its complication, to provide hemodynamic stability, to get an optimal sedation, not more sedation or less sedation or anxiety, and to get a very minimum side effect. So we have this ideal additive or not. Really, it is a very interesting adjuvant for peripheral regional anesthesia and additive review. And this is a conclusion. None of the potential medication investigated today fulfill all the criteria for ideal local anesthesia additives. Dexmedetomidine and dexamethasone demonstrate the most supporting evidence. The running study and many studies showing the good benefits, but still we need to know a lot about the studies because bizarre shape. We need to know the dose, side effect, and what's the optimal dose. And also coming into the horizon, magnesium sulfate may be promising additive in the future. And because we have a very scaring complication happen with local anesthesia and additive, we must look seriously about the dose and the speed of injection, the vascularity of the area, because we know from that the local anesthesia, most of local anesthesia is vasodilator except cocaine. And second thing, what we need the lowest dose to give the maximum effect. As we know in regional anesthesia, most of us scared from failure, and he considers this shame. Usually give more than dose, more and dose, more concentration to get an optimal effect. But really, it is a running study about the maximum effective dose 95. They found for intrascalene, for example, 8 ml get them 95% of the people to be blocked. For infraclav, supraclav, 18 ml get a 95% of the people to be blocked. So if you need 100, you just add half of this dose. So it is maximum for supraclav and infraclav 28 ml, and maximum for intrascalene is 12 ml can be blocked. And this makes case report about 4 ml can make a complete block. So maximum safe dose for the common local anesthesia, lidocaine because vasodilator with epinephrine 7 ml per kg. Without epinephrine, 3 ml per kg. With bupivacaine, whatever, with epinephrine, without epinephrine, it is 2 ml per kg. But remember, this dose can make toxicity because toxicity is not related only to the dose, it's related to the vascularity of the area, intravascular injection, and many other factors. So additional safety to know for additive, intravascular injection remains the most serious complication, and this can lead to immediate what's called local anesthesia toxicity. Again, ultrasound decreases the risk of intravascular injection, but not prevented. So don't be overconfident when you do your job. Lipid emulsification is very important and must be whenever you give a local anesthesia, you must have this what's called the antidote for local anesthesia systemic toxicity. Again, reduction of the dose of local anesthesia with ultrasound and guided block is well known now. As I remember when I started to make intrascalene, we can 30 to 40 ml in the neck. And now you can give an only 8 ml with ultrasound because the position of the needle more than important of many other issues. Again, treatment with alpha adrenal receptor attenuate local anesthesia systemic induced cardiotoxicity, and this is an animal study. I'm speaking about clonidine and dexmedetomidine. But remember, I'm telling you that adrenaline, if not coming to this time, 100 year, it's like remind me by nitric oxide. No one can use it because it uses this time because you need a long-acting local anesthesia and don't have long-acting at this time, only lidocaine and maybe Vicane. So it used just to increase the time about 30–40%. And again, you have now more safe drug to use, less complication because many issues about epinephrine like toxicity, and if you inject inside the nerve with what's called ischemic injury, the worst injury. Also, use of combination of additive, but also can give you some errors. So, additive, whenever you have a safety, you must be checked by 2 persons not to get any errors during putting an additive. Remember also using only preservative-free additive or local anesthesia to decrease the neurotoxicity. And this is hardly to find additive-free. Usually we speak about that, but most of us, you don't use an additive-free. And also looking for adjuvant in what's called optimal safe dose. Because you have on other hand, like a toxicity, not just local anesthesia toxicity, also you have what's called metahemoglobinemia. What happened with like brilocaine or chloroquine, and also it happened with many overdose for even with lidocaine it can happen. And remember also the local anesthesia systemic toxicity, which most of us don't make any attention about that, but neurological sequelae in these two studies are further complication, greatly underreported, not reported because we don't follow up the patient for many years. And we know that local anesthesia is neurotoxic and myotoxic and even chondrotoxic. And prospective observation trial assessing postoperative neurological sequelae alarmingly high rate of significant sensory symptoms and neuropathy, but we don't follow that. Again, the local anesthesia toxicity, like intra-articular injection, especially in advanced osteoarthritis, but we know that robuphicane is less risky than mebufotenin or bupivacaine. So how was additive? Additive maybe about another medication, as I told you, replace 1 by 2. So I can just put another local anesthesia or the local anesthesia. And this most people thinking logically it is right. I can just put anesthesia, one local anesthesia to other to change some of the character of the anesthesia, like physical character. If I put, for example, in IMLA cream, I put a mixture of lidocaine and brylocane, and this decreases the melting point and can give you a good penetration for local anesthesia. This happened, but I just now I'm speaking about local anesthesia additive for the adjuvant for the local anesthesia in peripheral nerve. And I found many papers, even I found paper in 1956 about mixing local anesthesia. What we think now logically, if I use lidocaine in a suitable amount with a long-acting one, ropivacaine or rivaroxaban or bupivacaine, what I get logically that I get a fast action and long duration. Is this right? Is this what we think? This is what I think when I started my career. And I think most people were thinking that. But if we're looking for the literature, this paper in 1996, they found if you put local anesthesia mixing lidocaine short acting, which are working fast with long acting, it's not working very fast as we think and not stay forever as we think, even decreasing at the time. And there is many paper, you know, whenever you go for the literature, you found many paper. So this one by Shokma et al. He found that combination of local anesthesia in order to achieve speed of onset and duration of block to get a good duration, increase the proportional lidocaine, even with bupivacaine, increase the amount of lidocaine to get more effect and what's called longer duration. They don't found. This is a conclusion. Not necessarily have the anticipated effect reduced by onset of block. This, as I told you before, that not all the science is logic and not all the logic is science. So what we found, not just to decrease the time to work and not to stay forever as we think, even decreasing the time and give unpredictable time again. And this is but also another group showing that Nakayama, mixture of local anesthesia. Even he writes that this is a conclusion for the study. Decision regarding the mixture of local anesthesia agent continue to be based on clinical preference rather than consensus. This is like a belief, not just an science. Again, this is study. The conclusion of adding long acting with short acting, which we think working fast, not demonstrate any rapid onset of lidocaine and duration of bupivacaine, even give a lower duration. Really, I found this is a diary from one of the famous, but he's a veterinary anesthesiologist. We don't have this job in our country, but he writes a very interesting thing about his residency, and he make many studies about local anesthesia and stuff like this. And he writes, I just let me to write for you. In my residency, when I first heard about some people speaking about mixing local anesthesia and bupivacaine for local anesthesia, it seemed like a reasonable plan. You get the best of the both worlds, fast onset of lidocaine and long duration from bupivacaine. By the time I had learned enough about pharmacokinetics of local anesthesia to think this is not logically working, sound right. It is common on the internet and in scientific publication. Even some publication found some publication given, but have a very what's called a wrong methodology, and they give some facts, you know, bizarre fact. And he said, you would think therefore there is a scientifically validated pharmacological rationale approach, but this is not. And especially after we published for 2013, Lazaraga published a study comparing lidocaine, bupivacaine, and bupivacaine block for regional anesthesia block, and then sensory testing. And when he studied that, he found that lidocaine bupivacaine group was shorter than bupivacaine group in their time, and the onset is the same. Again, he found in Visal et al. 2013 that onset time not better and duration was not longer. Mixing local anesthesia don't produce fast onset as we think, and even reduce the duration. It is not the best of the world. It is the worst of both. And they said, in my opinion, you end up 1% lidocaine, 0.25, lidocaine, sorry, 1%, and bupivacaine, 0.25. And this is a very important issue because one of the factors which increasing the time, decreasing the time, and increasing the duration is the concentration gradient. Penetration of the drug into the nerve and at least apart by concentration gradient, mixing them, you have diluted your drug and reduces concentration gradient. and this is not giving you what you think all the time. So mixing of local anesthesia is not a preferable thing. So what about the additive? First thing, we know that in additive, we have many narcotics, opioids like morphine, fentanyl, buprenorphine, diamorphine, tramadol, betadine, so fentanyl and diamorphine. We know from our practice that in regional and central neuralgia, we can use morphine, fentanyl, it can giving a good time, it can prolong the time, and we don't have a horrible side effect like an other side effect, but we can get what's called a more itching with central neuralgia. But in peripherally, because we have the concept to get an narcotics or opioid less anesthesia or free anesthesia, in peripherally, we don't have a very good number of narcotic receptors, so we get the same less effect, and the same also the side effect will be more horrible. And we are now in what's called a crisis, opioid crisis. We need to decrease the amount of opioid. So the only drugs which have some interest is buprenorphine, and we know that buprenorphine is opioid receptor mu agonist and the kappa antagonist. And he have analgesia and decrease in hyperalgesia, and can use in chronic pain even like a patch. And in early studies, as Candido et al. Demonstrated analgesic efficacy for additional buprenorphine or two combination of bupivacaine, tetracaine, and epinephrine. This is an early study, but he found in 2002. But the same group, when he studied in depth this buprenorphine, they found that the same group compared post-operative analgesia effect of buprenorphine added to bupivacaine for sciatic nerve block. They found the result is less impressive, and they don't give more advantage for the other groups, and it's the same. They give more nausea and vomiting and no difference in satisfaction. And also it remains unclear how this drug is working. Again, the second group is vasoactive agent. Epinephrine, which have an extensive study, and phenylephrine. Phenylephrine, the early study stopped because they give temporary neurological syndrome, which can continue for some patients to be permanent neurological syndrome. So when you speak about epinephrine, which is studied because a long time use study and using the character to make a vasoconstriction, less absorption for local anesthesia, and he can increase the time about 30%, on some study 50% from the time. It can give you a few hours more. But you must know how it works. It's just a vasoconstriction only of have analgesia, we don't know. This is need to be questioned, but adrenaline, epinephrine alone don't have any analgesic effect. But you must remember, if you injected like an IV or have an absorption, you have an anxiety and restlessness, headache, or weakness and palpitation. And this is usually confused with toxicity of local anesthesia. And many cases of adrenaline injection treated like an local anesthesia systemic toxicity. And remember also that the worst thing about adrenaline is a ischemic injury. If you inject inside the joint, the nerve, there is many injuries can happen for the nerve, like traumatic injury, toxic injury from local anesthesia, and ischemic injury. And the worst outcome is the ischemic injury if you inject inside the nerve. And this is a concern about norepinephrine or just epinephrine. Also, it's widely used, and it's used from the repetition. At that time, no more medication. But now we have a very long acting. You can add it, put a more safe additive than adrenaline. For me, I don't use it for 5 years, last 5 years. Inclusive also the interest of ultrasound guided nerve block is just debated more and more the interest in using norepinephrine. In 2013, some researchers found that change on the blood supply of the nerve, which can be reduced to 660. And we don't know now how is not adrenaline, how it makes the toxicity, but we have an animal study about it, but this is not reflected to human studies. Also in this study, epinephrine has analgesic benefit was used in short-acting local anesthesia. But with long-acting, we don't have any benefit, and we needed to make a long-acting. If you need a long-acting, use a long-acting. Don't put an additive like epinephrine. Also, in Welsh, B and his colleagues just discovered some fact about adrenaline. It is a lot of argument about protective function for adrenaline just to decrease the toxicity. And again, I tell you that some people still insisting if I use it to judge that I inject intravenous or not. And sometimes this will give you like symptoms of local anesthesia, systemic toxicity. And if the patient gets a beta blocker, it's common drug in all the age now, they don't give you this change, what you say. This is some word about complication of adrenaline, especially in a sick nerve, if your patient have a diabetes, hypertension, smoking. Also, he said intraneural injection is devastated complication. They found also in animal study that addition of epinephrine to local anesthesia may increase neurotoxicity. Second drug to use, this is a corticosteroid group. The extensive studies now for dexamethasone, which is mechanism of action, it decreases inflammatory mediator, it reduces ectopic discharge, not just anti-inflammatory, it is a negative neuromodulator for the nerves. He can decrease the neural discharge, inhibit potassium channel, prolong nerve block. It can give a time from 1 hour to 6 hours in time, improve the quality and duration of anesthesia. They found there is no difference between intravenous or neural injection, but there is some debate about that. There is studies, some studies said about that just pre-neural more effective than intravenous, and even the dose. They found that no difference between 4 milligram and 8 milligram in injection for the perennial effect. So this interesting study is showing the difference between adjuvant drug and what's the best. But still, even this 2021, it's still some debate about that. And in this conclusion, he compared to clonidine, dexmedetomidine, and dexamethasone, which is very common. And he found that dexamethasone is more better in time and quality of analgesia. But still some debate about this. Also, we have another group. It's called the alpha-2 adrenergic agonist. The most common drug is clonidine, dexmedetomidine. And they have a very good action as analgesic, and they have a sedative action also, analgesic action, sympatholytic, and decrease sympatholysis and give some sedation and hemodynamic stability in a normal and regular dose, but in higher dose can get a bradycardia and hypotension, and they have local vasoconstricting effect. From the study, they found that clonidine, they have some extensive study more than clonidine, but now shifting for dexmedetomidine because more selective. They found he gave a nerve block by alpha-2 adrenergic agonist effect and give some sedation and enhance it. This is extensive study in neuroaxial, and it used even in intracecal, but this is out of box. It's not approved by many society. And again, if you read about 100 microgram clonidine, give you a mild treatable side effect, it may be not for our patient. Usually our patient from the desert, if you give this dose, all the patient get on side effect. So I think we need to adjust the dose for our patient and to be cautiously about the dose. And you must know that the bradycardia and hypotension need a very higher dose of atropine or other drug to reverse this action. And there is many studies about to show analgesic benefit in addition to clonidine, but we need also the duration of action difficult to assess because there is many bizarre study and every study different from each other. And clonidine 100 to 5 give you 100 to 500 additional minute for long action for local anesthesia. But the study is still running and we don't have what's called an fixed opinion about or evidence about the dose, the duration, all this stuff. Another study showing that using of clonidine, it can give you 2 to 8 hours more. The adverse effect was minor, even with 100 microgram. But really, when I use that for our patient here in the desert area, it gives a horrible side effect. And also optimal dose still remain unknown. This is a dexmedetomidine and more selective, have the same action, but more selective, more than clonidine, and decrease the post-operative shivering. You have a good action for that. It gives a very good sedation. It uses intracecal and binaural. And I found it interesting this drug, but don't use a dose which is written in the book for our patient. You can do because I think there is some genetic factor different from 1 to 1. In a prospective randomized blind double control trial found that improved onset of time and it gives you a short time and increase the duration for analgesia of dexmedetomidine, but it's 150 is very high dose, as I told you, was added to buprenorphine for axillary nerve block in human. Dexmedetomidine was associated with more bradycardia and hypotension, especially if you do that for a sitting position for intrascalene or shoulder surgery. But we know now from animal studies have a cardioprotective effect, and you can increase the dose with less toxicity. We don't know even for that is for human being, but this is just animal study. This is a study about dexmedetomidine, and they found to give you 4 to 6 hours. In some study, 2 to 8 hours, according to the study group. What's called patient specific or maybe procedure specific. But you must know where the patient resistant to atropine need a higher dose if you get a bradycardia. What about non-steroidal anti-inflammatory? There is 2 drugs using as adjuvant, Pharmacokinetic, Buprenorphine, and Buprenorphine now is available in the market with an Zinylref. You know that the COX-2 inhibitor reduce inflammatory mediator action or decrease the action of prostaglandin. The role is central more than the peripheral, even what's called paracetamol using a central and sometimes give some sedation in some study. So COX-2 inhibitor on a spinal more than effective, but it's used now for with an there is many combination 4 milligram of Meloxicam or 8 or 12 Meloxicam with bupivacaine. And you know the conclusion of the study, bupivacaine Meloxicam prolonged release is a long-acting local anesthesia now is approved for treatment post-operative pain and can give you 3 days or more, 5 days, 6 days analgesia. Bupivacaine Meloxicam prolonged release reduce post-operative pain, opioid consumption, and this is a very good target. We have many other agents. You know that I found about 32 agents can be used an additive, but most of them still under study like ketamine, midazolam, nocigmine, robredol, magnesium sulfate, sodium bicarb, potassium chloride, even adenosine, verapamil, dextran, and hyaluronase. So I'm just speaking a few words about ketamine as an adjuvant. There is many study done about it, and they have many mechanism of action, can decrease the dose, but the problem with ketamine is a side effect which happened with use of ketamine. Usually those use 0.5 to 1 milligram per kg, but remember that preservative-free esketamine, levoketamine is less side effect than the other. Maybe just coming to the surface to make some study on esketamine to helping, but you don't use it usually intrathecal because of horrible side effect. The midazolam is used for many study intrathecal, and is GABAergic and opioid receptor antagonist. It can be used intrathecal, and there's a little study showing that using for perineural, but using intrathecal can increase the time and not suitable for decreased surgery, decrease the post-operative nausea and vomiting. I won't speak about the dose, but you know, neurotoxicity is a concern about midazolam because animal study have many concerns about transneurological syndrome. But there is a study or study in 1,100 patients by Trucker et al. Prove that neurotoxicity of midazolam is not associated with any neurological problem, but still you don't have a solid evidence to use and midazolam. Just I'm showing that, but don't hear from me that midazolam can be used. You go for to use it. Don't use an extreme medicine in your life. You know, it's still many debate about the safety issue. What is the dose? How there are many debate about effect or neurotoxicity. So magnesium sulfate is one of the coming drug because it's considered physiological. And this magnesium sulfate working like ketamine, like on the N-methyl aspartate antagonist, moderating sodium influx, because sodium is firing a neuron, is firing ions to the tissue, and magnesium is a physiological antagonist for the calcium. So magnesium in this study shown Goodman and et al., magnesium decrease peripheral neuroexcitability and excitability and enhance the effect of lidocaine. He can give you fast action and long duration. Very high dose to remember of magnesium, which can make a toxicity, can give an temporary or permanent neurological syndrome. And this is in this study, he gave an preeclampsia 50 milligram intrathecal magnesium, but I don't know if this preservative free or not. With ropivacaine, what they found? They found epidural magnesium prolongs the time for first rescue analgesic, lower incidence post-operative shivering, nausea, and vomiting, and fast onset, longer duration, reduced breakthrough pain. It's very important, and not change any, no have any adverse effect for fetal outcome. But also it used now in many blocks like interscalene, supraclavicular, femoral, and you have some promising earlier results. Increasing the duration with less side effect, and further study are needed. Don't use it until we have a solid evidence about use it. Further study are needed for that, but don't forget that it can produce bradycardia, hypotension, sedation, headache and hot flashes if you're given fast, absorption given fast, disorientation, and pre-umbilical burning pain. So this study is just coming new in 2021 about using magnesium sulfate in peripheral nerve block, and update, meta-analysis, and systemic review. Magnesium sulfate, the conclusion: magnesium sulfate enhances the anesthetic effect of local anesthesia and to improve the post-operative analgesia. Magnesium sulfate reduce the incidence of nausea and vomiting and transversus abdominis bleeding block. So sodium bicarb, usually using sodium bicarb, especially in local anesthesia for in area of infection, or to increase the time for local anesthesia. And what we think is that decrease the time to block and increasing the duration for the block. What we found that he can increase the time of increasing the shortening the time for block, but unfortunately from the study, they don't increase any time for block. And the mechanism of action, because you give more free non-ionized ion to be bypassing the lipid membrane to go faster, because the non-ionized is going more faster than ionized, because most of the local anesthesia and comedically is acidic, just to give a time for preservation for 3 to 4 years. Again, also this bicarbonate, which sodium bicarb, which just elaborated from sodium bicarb, just can make an acidity in the cell more and more, and can make an what's called ion trapping. This is would think that increasing the time of local anesthesia, but clinically or practically, they don't increase the time of local anesthesia, only enhancing the time of local anesthesia. And there is many study about that and what is the optimal dose for using. You don't increase the what's called block duration, as you know, because we think it's increase only make the local anesthesia working fast. And another thing in this study that if you give it, because sometimes you use a multiple additive, not just one additive. If you give it was clonidine, decreasing the time, offset the time of clonidine, don't increase get any effect. So to use it, because most of the time when you use sodium bicarb, you found your fluid become white and many reaction will happen, and this can be stable for more than a few minutes or just maximum 1 hour. So usually if you use it for volume for sodium bicarb, you need for 1 or 2, you need 2 ml for every 20 ml. You know, bupivacaine, you need only 0.1 ml because the reaction can make an unstable and can make it not working. So when you use it cautiously and use it what's called 20 ml for local lidocaine, you can use 2 ml. Bupivacaine, only 1.1 ml, not more than this. So, and you want to just come to the dextran, was low molecular weight, this dextran was 40,000 Dalton, because this is working like a carrier, like a liposomal for the local anesthesia. And there is a promising result now, but still in the early stage. He gives us safe and prolonged effective, and he can increase the time for days, 1 day or more days. And what we think from the mechanism may be a carrier for local anesthesia, like liposomal bupivacaine. And then this study showing that it can give a good result and less toxicity, lower toxicity, and give more profound analgesia, long-lasting analgesia. It can be more than for 24 hours. So what is the future for local anesthesia that? So directed towards the search of agent and technique. What prolonged local anesthesia and limiting side effect. Even they think about local anesthesia, what's called muscle relaxant from an what's called toxic snails to increasing the analgesia, but still under study. It includes technique to use it like a neuro delivery mechanism, which prolonged bioavailability, like liposomal bupivacaine, cyclodextran, and microsphere system, and this is coming in the future. We have only now liposomal bupivacaine. Use of drug like a dextran, adenosine, neuromuscular blocker, as I told you, toxic blocker. So this is one of the future things like I liposomal bupivacaine. I give you a few words about it. So the bupivacaine, if they approved for many blocks, formulation decrease the reliance on catheter and decreasing the side effect of catheter and even the cost. It can stay from 3 to 5 days. Again, it works like, you know, like a pomegranate. like a physical inside membrane, and there is a layer, membrane layer, and go with this local anesthesia very slowly, and to give you for a long time. And this is the approval of the FDA for many, and for European staff until 2010. I know that you come tired at the end because I bring you on the weekend, and most of us like this, searching for a coffee. And I know that time is squeezing, and I get more time. So my whole message or my conclusion for you as about the adjuvant. Adjuvant are medication that work with local anesthesia to improve the onset, duration, and quality. Greatly reduces the use of opioid analgesia, and it's a very good target. Adjuvant has developed from adrenaline. We have a very big arsenal from adrenaline to opioid to other drugs with various mechanisms of action. Only preparation was without preservative, since it can be produce a neurotoxicity for the tissue, for the nerve tissue. Alpha 2 receptor agonists are becoming the adjuvant of choice in anesthesiology practice. Magnesium is promising. Opioid most use the adjuvant neuroaxial, but the role of perineural is less and less, and still debated. Limited by its adverse effect as respiratory depression, nausea, vomiting, pruritus. Adjuvant is continuously evolving field in anesthesia, where newer agents in focus of research. Future efforts should be directed towards more controlled study that will be aimed at reducing dose of local anesthesia, increasing the analgesic effect, and zero side effect. At the end of the day, what do you need? To need for a happy patient, to get a happy patient and a happy physician. I don't speak about anesthesia. And like doesn't get better by chance. It gets better by change. And thank you very much for attending, for listening, and any question.
Thank you, very much, Dr. Yasser. Very interesting lecture. Thank you, very good effort. There's some questions from our colleagues. The first question from Dr. Mahmoud. He says, is it possible to get buprenorphine toxicity after spinal anesthesia with 11 milligrams of 0.5% buprenorphine?
Yes, you can, because look, I have a presentation in the media online about local anesthesia systemic toxicity. Because systemic toxicity can happen from intravascular injection, it need only increase the plasma level of the local anesthesia. So if you give it intravascular, it can be reduced. I remember a case of lateral cutaneous nerve of the thigh. We give only 6 ml of buprenorphine, 0.25%, and we get a toxicity. After that, because the toxicity not depend only on the dose, it depends on the area you inject, on the vascular, what's called absorption of the area. We know that, for example, intercostal is very, very high absorptive power for this area, and toxicity more instead of you give, for example, subcutaneous. So the toxicity depends on many factors, and genetic factors, depend on the dose, the speed of injection, and also for the vascularity. If you inject intravascular few ml, for example, if you're making for any block in the neck and injected only 1 or 2 ml, you can get all the manifestation of local anesthesia. It can happen.
Okay. Question number 2 here. He says, he asked about addition of adrenaline to local anesthesia to lidocaine in skin, okay, before skin incision. Some surgeons prefer to do this for hemostasis, for post-operative analgesia, preemptive anesthesia of the skin and the receptors. What about it? What do you think about it, sir?
Yeah, you know that what I'm telling you about the adrenaline came to this time. When it started to use it because there is no long-acting local anesthesia. It was an lidocaine only. It can be used. I don't say that it can't be used, but you know that you remember that the concentration, all the study was showing that adrenaline can make a sloughing, or in the arteries it was 1/20,000. But now we use 1/200,000, even 400,000. It can be used, but remember that is not an ideal for every block, because some people thinking it's ideal. Instead to use a buprenorphine, he needed long acting. He needed lidocaine lidocaine was adrenaline. This is not a good choice, but it can use for that because they have another action. I don't say that you can't use it because sometimes you use it in some areas, but be sure that it can't be used for everything like we used before because we have many options now and more safer drugs.
How do you know that the drug is preservative free and is safe to be injected intrathecal?
This is what I'm giving you and practical issue is totally different from academic. Most of the time we see that we have a drug is called ibumorphine. It's morphine, preservative free, but a very short shelf life. You know, I remember when I was in Saudi, they bring this medication. I think that the shelf life was 6 months. So when we bring it, you only 1 month to use it. So most of the people using without preservative free is a wrong practice. But even I found in some, even Western country, in some people which given preservative free given because this is a very rare to find a preservative free because preservation can increase shelf life to years, but without preservation you need just to use a drug in few months, and most of the time you don't have a preservative free. For me, I use an BPVK, I use an dexmedetomidine, dexamethasone. I don't know, not preservative free, but we don't have, and most of the area we don't have. You have a Dr. Saab? You have preservative?
Yeah, we do. We do indeed. We have fentanyl, we have clonidine, we have most of the stuff intrathecal should be preservative free. You know,
we don't have, but most of the people in other parts of the world use it without preservation.
Another colleague is asking you, sir, about using intrathecal.
We don't hear you, Dr. Tahir. Again, you can. Hello? Dr. Tahir?
Asking about intrathecal histamine.
Yeah.
Sir?
Yeah. Intrathecal histamine, there is many study about it, but most of the studies stopped because of horrible post-operative nausea and vomiting. They can't stop the vomiting with the patient. I remember when I was a resident, one of my colleagues was making an MD for intrathecal local anesthesia. I was helping him, and no patient without coming post-operative nausea and vomiting because they use from 5 to 15 might, 50 might for intrathecal. But the study stopped because we don't know that what is the ideal dose which give you a good analgesia and preventing post-operative nausea and vomiting. So don't use extreme, my opinion. Don't for general stuff. Don't use extreme medicine. You know, because there is another safe drugs. Why use it? It's okay.
Okay. Yeah. Thank you, sir.